Welcome to Outbreak Brief, the podcast that takes you inside the world's most dangerous infections. Today, we are looking at a pathogen that relies on ultimate stealth, quietly infecting hundreds of millions of people in total silence and stealing human sight and fertility before its victims even know it's there. Okay, let's unpack this.
Yeah, to really understand this threat, you have to look at its primary weapon. And that's not, immediate dramatic death. Its primary weapon is absolute invisibility. I mean, in the United States alone, this is actually the single most commonly reported bacterial infection.
Which is wild. I mean, think back to the year 2020, right?
Oh, yeah.
The entire globe was locked down. We were all hyper-fixated on a loud, deadly viral pandemic, washing groceries, wearing masks. But while the world was completely distracted by that one massive threat, another pathogen was just quietly slipping through the population, completely unnoticed. In that single year, it infected an estimated 128 million adults across the globe, moving almost entirely in silence. I always picture it kind of like a home invader, but not the kind that smashes a window or kicks down your front door.
Right, it doesn't want to make a scene.
Exactly. This invader uses a master key. It just slips inside your house without making a sound and then quietly changes the locks from the inside. By the time you realize you've been robbed, the damage to the house is already permanent.
That is actually a really fitting analogy for Chlamydia trachomatis, which is the pathogen at the center of this deep dive today.
So what exactly are we dealing with here?
Well, biologically speaking, it is a gram-negative, anaerobic, intracellular obligate bacterium.
Okay, let's break that down a bit for people.
Sure. So those last three words are really the entire key to its survival. Intracellular obligate bacterium. It basically means it cannot survive, let alone reproduce, on its own out in the open.
So it's completely obligated to hijack a host.
Exactly. It has to hijack the internal machinery of a living human cell.
And getting inside that cell, that requires a pretty brilliant evolutionary trick. Rather than just breaking in, it acts like a microscopic Trojan horse.
Yes.
It starts out in a form that researchers call an elementary body. So think of this as the wooden horse. It's heavily armored, it's metabolically inactive, and it's designed solely to survive the harsh environment just floating around outside a cell.
Right. It's basically a spore-like capsule at that point.
Yeah, and it bumps into a human cell and essentially tricks the cell into swallowing it through a process called phagocytosis.
And the human cell just thinks it's engulfing some random debris to dispose of it. Normally, when a cell swallows something foreign like that, it sends in lysosomes.
The cellular security guards.
Exactly.
Yeah.
These security guards, they're basically packed with acid to destroy the invader.
But this is where the Trojan horse deploys a cloaking device.
Yeah.
Once it's inside, the elementary body wraps itself in this protective membrane called an inclusion vacuole. So the cell's security guards literally can't see it.
They just bypass it entirely.
Right. And safe inside that little bubble, the bacteria takes off its armor and transforms into its second phase, which is the reticulate body.
And the reticulate body is the active parasite. Once it transforms, it aggressively devours the host cell's energy, its ATP, its amino acids. It just rapidly clones itself inside that hidden bubble.
Right, until there's nothing left.
Right. Once it has exhausted all the host cell's resources, those clones revert back into the armored elementary bodies, pop the host cell open like a balloon, and just spill out to infect all the neighboring tissue.
It's honestly terrifying. But what makes this pathogen even more complex is that it's actually a shapeshifter, depending on the specific strain you encounter.
Yeah, it has 18 distinct faces, essentially. We call them serovars, and they have very, very different targets.
Science groups them based on the diseases they cause, right?
Yes.
Yeah.
So serovars A, B, B, and C, they cause a really severe eye infection called trachoma. Then you have serovars D through K, which are responsible for the genital tract and neonatal infections that we typically associate with the word chlamydia in everyday conversation.
Yeah.
And finally, you have serovars L1, L2, and L3. And those cause lymphogranuloma venereum, or LGV, which is a much more invasive systemic disease that actually attacks the lymphatic system.
Because this bacterium is so perfectly adapted to hiding inside our own cells, its history is deeply intertwined with human blind spots. If you look at those first serovars, A through C, causing trachoma, we tend to think of chlamydia strictly as an STI in Western clinics.
Right, a purely sexually transmitted thing.
Exactly. But globally, different strains of this exact same bacteria are the leading infectious cause of blindness in the world.
If we connect this to the bigger picture, you see a disease that has historically ravaged parts of Africa and Asia. Trachoma isn't just a simple eye infection where you take some drops and it goes away.
Yeah.
It's a chronic cycle of repeated infections, and it often begins in early childhood.
The biological mechanism behind that blindness is just incredibly cruel. Over years of these repeated infections, the inside of the eyelid becomes severely scarred, and then that scar tissue contracts.
Which is what pulls the eyelid inward.
Right, it causes the eyelid to physically turn inward. It's a condition called trichiasis. And so every time the person blinks, their own eyelashes scrape directly across their clear cornea.
Oh, it is a constant physical trauma.
Yeah.
Just relentless scraping. Over time, that causes the cornea to cloud over entirely, and it leads to irreversible blindness.
Mechanical destruction of the eye, just initiated by a microscopic bacterium.
And we are seeing major shifts in the other strains, too. Take LGV, for example.
Yeah.
For decades, that was considered a tropical disease, something you would rarely, if ever, encounter in North America or Europe. But today, we are witnessing a global resurgence of LGV, particularly within networks of gay men and men who have sex with men.
Because the pathogen adapts.
Exactly. It evolves alongside human behavior. So to understand how it maintains such a massive global footprint today, we really have to look at exactly how it moves from host to host.
It has a very specific target cell, right?
Right.
The bacteria is hunting for squamous columnar epithelial cells.
Yes, and it's important to understand why it targets those specific cells. Squamocolumnar junctions are basically transition zones in the body.
Okay.
They're the exact borders where one type of tissue turns into another. So, like where the tough outer cells of the cervix meet the much more delicate glandular cells inside the cervical canal. You also find these vulnerable transition zones in the conjunctiva of the eyes, the urethra, and the rectum.
And these cells are highly metabolically active, but structurally they're pretty fragile. So they're the perfect soft entry points for a parasite that needs to penetrate a cell quickly.
Exactly. For the urogenital strains, transmission requires direct contact with that infected tissue. So primarily through vaginal, anal, or oral sex without a condom. It can also pass from a pregnant mother to her newborn during childbirth.
And the eye infection strain spreads differently, right?
Yeah, trachoma spreads mostly via contact with infected eye and nose discharge.
Right.
So it often transfers really rapidly among young children and their caregivers through, shared towels or unwashed hands.
But here is the massive puzzle piece for me. If this bacteria is so incredibly common, why aren't clinics just completely overflowing with symptomatic people the moment they get infected?
Because of the incubation period. After exposure, it can take anywhere from 1 to 3 weeks for any symptoms to appear.
Wow.
And for the vast majority of people, symptoms never appear at all.
So they just act as an asymptomatic engine?
Right.
You can feel completely fine, have absolutely zero pain, and yet you are unknowingly shedding thousands of these infectious elementary bodies, passing them to new partners.
Yeah, the R0, which is the basic reproduction number, remains consistently high in certain networks entirely because of this silent window. Because this silent phase allows people to continue their normal lives totally unaware. The disease just naturally funnels into the most vulnerable corners of our society.
And the demographics really bear the brunt of this epidemic. The highest rates of infection are found in youth aged 15 to 24.
And young women are hit especially hard, with reported rates roughly double those of men in that same exact age bracket. Yeah. And we also see a very strong epidemiological link between lower socioeconomic status and higher risk of infection.
Which makes sense. I was actually looking at a staggering study out of New York State that looked at repeat infections. So people who tested positive, got treated, and then tested positive again within like 30 to 365 days.
Oh, the rapid reinfections.
Yes. The highest rates of these rapid repeat infections were among young Black individuals, specifically teens aged 13 to 19, who had a history of prior STIs.
What's fascinating and tragic here is how clearly that highlights a vicious cycle. You really cannot separate this pathogen from the environment it thrives in.
So what does this all mean for the listener? I mean, if you were looking at this from a public health perspective, you realize you can't just treat this as a purely biological event.
No, not at all.
The structural barriers to healthcare, the lack of access to routine testing, the societal stigma around sexual health, these aren't just social issues. They are the exact environmental factors that physically fuel this bacterium's survival.
And we cannot ignore the dire risks it poses during pregnancy either. For pregnant individuals, an active infection elevates the likelihood of premature rupture of membranes.
Where the amniotic sac breaks too early.
Right, and that leads to preterm delivery. So you're looking at a pathogen that directly threatens the next generation before they're even born.
But this silent phase doesn't last forever. When the pathogen finally breaks its silence, the illusion of safety just shatters. I mean, we call it a silent epidemic because over 80% of women and a massive percentage of men have zero or very mild symptoms initially.
Right.
For women, early signs might just be a slight abnormal discharge or postcoital bleeding, something easy to ignore.
But if the bacteria manages to climb higher into the upper reproductive tract, it triggers pelvic inflammatory disease, or PID.
Here's where it gets really interesting, biologically speaking, because when we talk about PID, the biology of what's actually happening is intense. When the bacteria climb up into the fallopian tubes, your body's immune system detects them and sends in this massive army of white blood cells.
And the resulting battlefield creates massive inflammation.
Right. Now, fallopian tubes are incredibly narrow. They're lined with these delicate, tiny, hair-like structures called cilia that are supposed to sweep the egg toward the uterus.
And the inflammation, along with the healing process that follows, lays down dense scar tissue over those cilia.
It's like paving over a delicate ecosystem.
Exactly. That scar tissue acts like a physical roadblock, so the egg gets trapped. And if a sperm reaches it there, you get an ectopic pregnancy.
Which is a severe, life-threatening emergency.
Yes, very often fatal if untreated. And if the tube is completely blocked, it just results in irreversible infertility.
So the bacteria isn't actively trying to sterilize the host. It's the sheer violence of our own immune response that destroys the reproductive architecture.
It's friendly fire, essentially. And there's also a fascinating, albeit super painful, complication of this upward spread called Fitzhugh-Curtis syndrome, also known as perihepatitis.
This blew my mind when I read about it. The infection actually travels up through the peritoneal cavity and inflames the capsule wrapped around the liver.
Yes, it creates these adhesions that literally look like tiny violin strings stretching between the liver and the abdominal wall.
Wow.
It mimics liver disease. So the patient comes in with severe right upper quadrant pain, breathing really hurts, but if you check their liver enzymes in their blood, they are completely normal.
Because the liver itself is perfectly healthy.
Right, it's just the wrapping around the liver that is inflamed.
For men, the symptoms typically involve urethritis, which brings this burning sensation when urinating and a white or gray discharge.
And it can also travel down into the testicles.
Right, causing epididymitis, which presents as unilateral testicular pain and swelling. But there's also this bizarre autoimmune complication that affects both men and women, though it's definitely more prominent in men. Reactive arthritis.
Formerly known as Reiter's syndrome, yeah.
Right.
About 1% of men with chlamydia urethritis will develop this. It triggers a triad of symptoms. You get arthritis in the large joints, like your knees and ankles. You get urethritis. And you get uveitis, which is inflammation of the eye.
I was looking into how this actually happens, and it comes down to a trick called molecular mimicry. The proteins on the outer surface of the chlamydia bacteria look remarkably similar to certain proteins naturally found in human joints and eyes.
It's like wearing a stolen uniform.
Exactly.
Yeah.
So when your immune system generates antibodies to hunt down the bacteria, those antibodies essentially get confused. They start friendly firing on your own body.
It is a devastating misdirection by the immune system. We also mentioned the neonatal nightmares earlier. If a mother passes it to her baby during a vaginal delivery, the infant faces a 5% to 30% chance of developing a very specific type of pneumonia.
Right, and it's characterized by a distinct, repetitive staccato cough.
Yeah. Or they can develop inclusion conjunctivitis, where the inside of the eyelid takes on this bumpy cobblestone appearance.
And let's not forget the LGV serovirus we touched on earlier. When LGV strikes, it operates completely differently. It starts with a small, often painless genital ulcer. But that's just the entry wound.
Right. The real damage is deeper.
Exactly. The bacteria then travels deep into the lymphatic system, specifically the lymph nodes in the groin, causing severe swelling called buboes. And these can eventually rupture into chronic oozing lesions.
And if it infects the rectum, it causes severe proctocolitis with intense pain, discharge, and bleeding.
Seeing the sheer mechanical destruction it causes, from blinded eyes to scarred fallopian tubes and ruptured lymph nodes, you really have to wonder how modern medicine actually dismantles this thing once it's entrenched.
The good news is that we have a highly effective weapon. It is completely curable with antibiotics.
Okay, that's a relief.
Yeah, first-time therapy has about a 95% effectiveness rate, provided the patient actually completes the entire course of medication. The modern arsenal relies primarily on two heavy hitters, doxycycline and azithromycin.
Let's look at how they actually work. Doxycycline is a tetracycline antibiotic. It works by entering the bacterial cell and binding to its ribosomes, essentially shutting down its ability to make proteins.
And if the bacteria can't synthesize proteins, it cannot maintain its structure or replicate at all.
For uncomplicated urogenital cases, the standard is a 7-day course of doxycycline pills. For those intense LGV cases, it requires a grueling 21-day course.
Yeah, that's a tough regimen.
But then azithromycin, on the other hand, is a macrolide antibiotic. It also targets the ribosome, but in a slightly different location, and it can be given as a single, massive 1-gram dose, which raises an obvious question for me. If there is a single-dose pill, why not just give everyone that one pill? We know how terrible people are at finishing 7-day antibiotic courses.
It's a great question. A 2019 Cochrane review looked exactly at this, and they found that azithromycin actually has slightly higher microbiological failure rates compared to doxycycline. Doxycycline is just simply more thorough at eradicating the bacteria from those cellular hiding spots.
Ah, okay. But public health often requires intense pragmatism, right?
Exactly. If a clinician believes a patient is highly unlikely to adhere to a 7-day regimen, directly observing them, take that single 1-gram dose of azithromycin right there in the clinic is vastly better than handing them a prescription they just won't finish.
That makes total sense.
Additionally, doxycycline is strictly contraindicated for pregnant women because it can affect fetal bone and tooth development. So azithromycin becomes the vital alternative in those cases.
Okay, so curing the infection with antibiotics is one thing, but preventing the next invasion is an entirely different battle. Because the antibiotics are so effective, you'd think we could just, treat our way out of this.
You'd hope so.
But that brings up the elephant in the room. Once you've taken your doxycycline and cleared the infection, is your body actually prepared if that same home invader comes back?
That is the harsh reality of Chlamydia trachomatis. There is zero lasting natural immunity.
None.
None. You can be infected, cured, and reinfected weeks later, usually because sexual partners weren't treated simultaneously.
But why doesn't the immune system remember it? I mean, we have vaccines for HPV, for hepatitis B. Our bodies know how to build memory.
It goes back to the inclusion vacuole, that cloaking device inside the cell we talked about. Because the bacteria spends almost its entire life cycle hiding inside your own cells, it barely exposes itself to the bloodstream, where the immune system actually builds its long-term memory.
So a vaccine would have to be incredibly precise.
Imagine trying to design one. A vaccine's job is to show the immune system a piece of the pathogen, an antigen, so it can remember it. But if you use an antigen from the chlamydia outer membrane, and that antigen looks just like human joint proteins.
The molecular mimicry.
Exactly. A vaccine could theoretically trigger the exact same autoimmune reactive arthritis we just talked about. So you'd be causing the disease you're trying to prevent.
Wow.
Yeah. It remains the holy grail of STI research, but we just aren't there yet.
So since we can't rely on a vaccine, we are forced to rely on behavioral and public health armor. On an individual level, correct and consistent condom use is really the only physical barrier during sex.
And a crucial rule that often gets missed, if you are infected and treated, you must abstain from sexual contact for 7 full days after taking the medication to ensure you don't pass it on.
Right. On a public health level, clinical screening is our main line of defense. The U.S. Preventive Services Task Force strongly recommends annual screening for all sexually active females under 25, older women at increased risk, men who have sex with men, and individuals in correctional facilities.
And the diagnostic gold standard for that is the Na8, nucleic acid amplification testing. It's highly sensitive, it looks for the genetic material of the bacteria itself, and it can be done via vaginal swabs or just a simple first catch urine sample.
We also deploy structural prevention for newborns, right?
Yes. To prevent that blinding trachoma conjunctivitis from maternal transmission, there is a global ocular prophylaxis protocol. Healthcare workers will literally smear an antibiotic ointment, like erythromycin, tetracycline, or povidone iodine, into every newborn's eyes immediately after birth.
But even that has risks. Treating neonates with macrolide antibiotics like erythromycin carries a rare but serious risk of infantile hypertrophic pyloric stenosis.
Right, which sounds incredibly scary for parents.
It is. Essentially, the muscle between the baby's stomach and intestines thickens, causing an intestinal obstruction. Parents and doctors have to watch carefully for symptoms like severe vomiting, so it is always this delicate balancing act. Knowing all these tools we have, the antibiotics, the genetic testing, the public health protocols, where does the human race actually stand in this war today?
Well, the global snapshot is sobering. We are dealing with an incredibly robust endemic pathogen. with over 128.5 million adult cases worldwide, affecting roughly 4% of all women and 2.5% of men globally between the ages of 15 and 49. It is absolutely thriving in the shadows.
Despite our advanced antibiotics, the socioeconomic drivers and the brilliant asymptomatic nature of the bacteria mean we are currently fighting a purely defensive war. We are constantly chasing the spread rather than stopping it.
But researchers are not giving up. Looking to the future, the World Health Organization has set an ambitious 2022 to 2030 strategy, aiming for a 50% reduction in new chlamydia cases by 2030.
How do they plan to pull that off without a vaccine?
By fundamentally changing the testing landscape. Researchers are pushing hard for highly accessible point-of-care molecular tests. Right now, if you get tested, it might take days to get lab results back.
And people just go about their lives.
Exactly. In that time, patients are lost to follow up, and they continue spreading the infection. Point-of-care testing would mean you get diagnosed and handed the medication in the exact same visit.
That would be a massive game changer for breaking the chain of transmission. But it still leaves us managing the fallout of a remarkably successful parasite.
This raises an important question, really, about the nature of disease itself. We often judge the terror of a pathogen by its fatality rate, like how fast does it kill the host? But the greatest evolutionary success of Chlamydia trachomatis isn't its ability to kill us, it's the exact opposite.
Right. By keeping us perfectly alive, but silently stripping away our ability to reproduce via infertility and ectopic pregnancies, it asks a profound biological question. Who is really mastering whom in this parasitic relationship?
Yeah.
It's thriving by quietly turning off our biological legacy while ensuring its own.
The ultimate parasite. It secures its own future by stealing ours. A chilling realization to mull over.
Stay informed, stay prepared. This has been Outbreak Brief.